I'd like to invite Professor Gareth to give some input, or what's your thought about pediatric DTG, particularly for this region.
Good afternoon, and thank you. And I feel very honored to be here. My name is Gareth Tudor Williams, and I've been working with children with HIV since 1987. And I went to do my fellowship training at Duke University in 1989 and participated in the very first PK studies that informed the 076 trial, just to reveal the dinosaur on the platform here. And in fact, I went to work at the NIH with Phil Pizzo, which was an incredible privilege back in 1991 as a visiting fellow, visiting scientist with the Fogarty organization. And Phil had this vision for children that absolutely pushed every agenda to make sure that there was a line item in the congressional budget for pediatric HIV back in 1991. And the data on DDI, which is a drug that I hope many of you have never even heard of, because it did have some problems, but it was actually licensed in children at the same time as it was licensed in adults by the FDA because of that visionary approach and that passion for making sure that we put children up there on the agenda internationally. And that was my training, and it's carried forwards through more than 3 decades of working with different organizations. My main work has been at Imperial College in London, but I've been very privileged to work with big organizations, particularly Penta, in terms of doing clinical research at international level. It's very lovely that Penta started off as the Pediatric European Network, and that very quickly expanded to include Thailand. I like this definition of Europe that no longer includes the UK, but does include Thailand. I think these 2 talks have been so helpful in setting the scene for this crazy situation where every country has to go through this ludicrously laborious system. I'm very interested to hear from colleagues in the room and on the panel about how that could be better dealt with, because, fortunately, of course, dolutegravir may be the most important drug, and we're not going to see the same need for coordination for newer preparations. We can discuss that, long-acting drugs and so on for children. But wouldn't it be great if WHO could submit on behalf of children globally in low and middle-income countries and avoid all of this? I was talking just a couple of days ago to colleagues in South Africa, prompted by this roundtable discussion, to find out when they will have access to the 10 milligram dispersible pediatric formulation. And they, just like Thailand, the South African authorities, the equivalent of their FDA, granted approval for the pediatric formulation back in July 2022, but that just missed the deadline for the procurement cycle. So they couldn't put in the procurement application last year. So they will not get 10 milligram dispersible tablets for their children, and they're still, all the under 5-year-olds are still on lopinavir and having a struggle in South Africa. And you will be well aware that the numbers infected with HIV in South Africa are still huge. I also have been very much involved in the outbreak, I don't know whether you've heard about this, in Pakistan, where through really lamentable clinical practice, a whole load, more than 1,500 children in northwest Sindh became infected with HIV, many of them co-infected with hepatitis B and or hepatitis C. And they also have not procured dolutegravir. Well, you can imagine, with that degree of bureaucracy in a country that has been living under 8 to 10 feet of water, with the flood damage, it becomes just too low a priority in public health terms. When half the population have got cholera, it's a very different situation. So there's a huge amount to learn about this. What I admire most of all is the tenacity of everybody on this panel and I'm sure in the audience to make our voices heard on behalf of children and make sure that we overcome those barriers and do not let any grass grow before we can get the optimal treatment for children. I just want to finish with one final point, which is to say, I would like to say thank you to the Odyssey team. So Odyssey was really a pivotal trial that was coordinated through the MRC Clinical Trials Unit in London with Professor Di Gibb and Anna Turkova, but also involves colleagues in this room. It was an extraordinarily important study to demonstrate the value of dolutegravir first line and second line in children, but it also provided all of that pivotal data on pharmacokinetics in the smaller kids. There was just one tiny thing I'd like to take issue with, Annette. It's so confusing the way these things are written, but the bioavailability of the dispersible formulation is 1.6 times higher than the film-coated tablet. Right. And on your slide, it says it the other way around, but I know that that's what you said in when you were speaking. But it is just important to clarify that, so that 30 milligrams of the dispersible formulation is equivalent to 50 milligrams of the film-coated tablet. And thank you, Tim Cressy, for letting me know that it wasn't me that was confused. Right. So I'd like to hand over to my colleagues to lead the discussion.
Yeah, well, thank you, thank you, Gareth. I think this is a good point, and thanks to the effort, and you can see that sometimes the FDA, they keep their standard. It's just like they have to do everything according to their rules. Regardless whether this is the drug that have been approved, advocated by the WHO, is in the guidelines, national guidelines, international guidelines. They continue to ask every single thing, just like the drug that have never been proven or never been in the guidelines or never, been used. And, because of the loss of interest of the originators, Dr. Rangsima has to be the one who provide all those information, in order to make the approval to the essential drug list and the Thai FDA, So we have to do a lot of things, that we're supposed not to do. And I really like your idea that you should voice really loudly to the WHO that this kind of drug should be provided by the WHO and overrule all those, requirements for registration and so on, which takes a lot of time. So I open for the arguments.
May I ask about comment from Dr. Annette about digital world, like e-commerce and access by buying things on internet? Because I think there are two main obstacles that it's very attractive to buy something on internet. We do it all the time, everything, the commercial goods. But for pediatrics, because ARV is lifelong treatment, and it's also specialized care that sometimes you need medical care to provide you information. It's unlike adult that you use the same dose, and you can also, as a human right, to access to drugs that are available on the global market. But for pediatrics, it's have many obstacles to do that route to get drugs, because one thing that pediatric DTG is can use in many indications, and the generic one is very cheap. There are no barriers on price comparing to protease inhibitors or antiretroviral drugs at the beginning of the treatment era that is very expensive. The cost is a barrier. Now the cost is affordable, but just on the bureaucratic of make it available in the government settings in this country. So how we can use alternative pathway, in your opinion?
Thank you. I would clarify that not all online pharmacy sources are reliable. I think we know that that's the same thing for if we're shopping for something else for ourselves, we may not be able to trust the distributor. So being certain of the quality of the medicines that you receive is critical. And it's not clear how much online drug purchasing of a medicine like pediatric dolutegravir would be allowed across country borders. So within India, it may be fine to be able to procure it from an Indian pharmacy that you have a good experience with. And this is why I think the better solution for other countries is through the NGO and Buyers Club route. So non-governmental, non-profit organizations are included in the voluntary license between Viv Healthcare and the Medicines Patent Pool. So they are allowed to procure amounts of medicine. And so this is something that we're exploring now, but an NGO and nonprofit would need to take responsibility for that. And when we were dealing with raltegravir, some of you may recall, we tried to get raltegravir for children in this country and other countries. There was kind of a quiet buyers club that the Delhi network of positive people helped to coordinate. And so there were lots of meetings in Bangkok, just like this one. And so sometimes members of their organization would legally carry small amounts of raltegravir into the country and then give it to the person who had requested it as part of the buyers club. So it just needs to be some organization that is willing to do that consistently, and then they take responsibility for making the orders, identifying a reliable pharmacy, because they themselves are using that same pharmacy to treat their own children. And so I think this is where the trust comes in.
Because in the past, when we access to antiretroviral drug syrup at the beginning, at that time we have MSF, Doctors Without Border, or some NGO or some organization that try to coordinate and support, or Clinton Foundation. So I think if we quite difficult to go through the registration process, and it was less motivation, like Dr. Rangsima mentioned, that it talk about hundreds of children in each country. It's not commercial attractive. Maybe NGO also need to help. And if you are from NGO or from organization that you have some idea or deal with this situation, please feel free to raise your hand or share your idea to be able to help us mobilize this issue.
Yeah.
Oh, also,
Actually,
sorry.
yeah, go ahead.
If you are interested in learning more about a buyers club for pediatric dolutegravir, please feel free to leave your name and your email address at the Treat Asia booth. We're gathering this information now to find out what the order size, the total number of bottles, would be. Like literally this week, we're beginning to collect this information. So again, the Treat Asia booth, which is near the entrance of the hall, please leave your name and your email address, and then our team will get back to you. Thank you.
I think I like to hear the folks from the floor, or anyone from the region that also have the same problem with pediatric DTG access. I see Tim in the back. You want to say something?
I will now. I will now. You bring my name in, but no. So actually, I was just thinking out in my head there that I wanted to emphasize that one of the things we see that the clinical research is still critical to get these drugs approved, and Asia has been a huge help when getting dolutegravir approved. Not just for the U.S. and Europe. The first children that got DTG in the world was probably from Thailand, and before they made this DTG dispersible tablet, they actually had a DTG syrup, which Kunkanya and in Chiang Rai actually used, and then they said this syrup's not good, we should use a tablet. But that shows that, and in the Odyssey study, there's Thai children involved in these studies, and in Asia. So I think the fact that Thai, Asian children have been critical to get these drugs approved in other countries, we should definitely be able to benefit from the participation of these children in research to make it helpful for everybody so that they can also benefit. So I think that has to be a strong political argument to the company and to the government that, okay, we helped you get this approved, now make it available for our children. And not just the ones in the study, but outside. And I think your study, Tanyawi, in Bangkok of the pediatric dispersible and the others really help with the internal approval. Oh, we give it to children so it helps, but I think being part of that clinical research network helps not just dolutegravir, but other drugs in the future. So I think the clinical research, involvement is critical for moving these excellent drugs forward.
Thank you. So that's one of the pathways that we make our children earlier access.
Yes, I couldn't agree more. And in fact, it's quite interesting when you read the CHI reports. For instance, they had a program in sub-Saharan Africa, in Benin and in Nigeria, which are countries that traditionally have not done very well with leading the way in treating children, where you have clinical research taking place, and CHI catalytically procured the drugs to run the studies,
right.
Then you motivate the population, you motivate the healthcare workers, you motivate the patient population, because they can see the advantages, they can see the improved
right.
adherence, they can see the improved outcomes, and then they advocate even more strongly, and they get the drug into their population sooner as a result of participating in clinical research. So I think it's a really important point.
Yes. Yeah, I think one of the things is that because the requirement is so little, and like in Thailand now, if GSK with can just donate directly, why not? They have huge profit from vaccines, from other drugs, why not? That could be another pathway, but there is no really strong intention from the manufacturer side to really starting to donate, because the need is so little, but very important.
What about, for COVID, they were able to accelerate the approval of drugs. Why? Is there any pathway in Thailand for acceleration of, FDA approval? I mean, if there was COVID, they can do it just like that. But for HIV, can they do more faster processes?
Yes, I can share, because this was an issue that we found as well. The reason that actually the company, as I mentioned earlier, they started to apply the registration in July 2021. However, there were it needs the Ministry of Public Health to communicate with the Thai FDA in advance for them to understand that this is urgent, something like that, to expedite the process. If only the company talk to the Thai FDA, that's gonna affect anything, something like that. So it was delayed for many months until we realized that actually the ministry has to talk, and there was a pathway, as you mentioned, for COVID registration for new products and things like that could take a very short period. Yes, but the issue is that the company are required to prepare complete package for submission. If they forgot something, missing something, they have to go back and then prepare all the documents again. As Dr. Kunkanya mentioned, it's very detailed process because I understand that they want, in terms of safety, to ensure that everything's safe according to their regulations.
Right.
Yes.
So it's very funny for other drugs. The company, they putting their very effort to submit for the dossier for the registration approval. For this drug, it turned out that we have to ask them, please come and submit your dossier, And the funniest thing is that you cannot approve the generic drug until the originator got approval first. And this is something that we cannot do anything for the FDA. They keep their regulations, they are the regulator. Yeah, Annette, want to say something? Yeah.
I would like to encourage the audience in the room, if you have direct experience about dealing with access to pediatric DTG or other antiretroviral drug, please share your experience or share your thought.
Yes. So I hope we're gonna get pediatric DTG very soon. But meanwhile, we use adult DTG as needed. And I talked to Dr. David Berger that actually, even a little lower than 20 kilograms, you still can use 50 milligram DTG, It's okay. But say 16 to 20, you can. But, again, the pediatric one is much better. So we should have, right now we almost at the end because we already have received approval for the originator. So the generic make will soon be available very soon. Yeah,
I think
following that.
one of the issue is the pediatric DTG is dispersible into liquid formulation because some children, until the children can swallow pill usually at around age 7 or 8 years old. So that's just for clarification. That's why we still struggle to find a proper formulation for young kids.
Oh, they can crash. Yeah, okay.
Last question, it's more of a clinical one. So I think it's exciting that you can give DTG 50 from 20 kilograms. But the TLD is 30 kilograms.
Right.
And they want to take it once a day. So when would you switch someone from DTG? Would you give TLD to, once they get to the DTG 50, but you cannot give TLD yet, how low would you give the TLD? Because I think it's becoming more and more
at least 30.
So you would not go less than 30 to give TLD. So some people are thinking, 25, okay, just switch from 50, 50 separate formulations, and you can go to one tablet once a day. So it's just that 10 kilogram gap where people are thinking, how low could I push it? There's no data, but I think it's a question that more and more people are asking, I think.
Right. But you see, for young children, their parents can make them take the medications. So although it's not a single tablet regimen, we pediatrician can manage. Yeah.
Yeah, clearly you're raising an important point, and the problem with TLD is that this is tenofovir, not TAF. And
Exactly.
I think that we've had enough experience of really significant renal problems, particularly with tenofovir overdosing in that lower weight band. And I absolutely wouldn't give full dose tenofovir to a child under 30 kilos. I'm pretty careful under 35 kilos.
Actually, the WHO recommend that it's 35 up. Yeah. All right. Thank you so much. I think we have to move on to the next session. Thank you, my three distinguished speakers. Thank you.
So we have a big round of applause for speakers. Thank you.